Welcome to the sixth and final explainer in our Vestibular Physicians series from Australian Dizziness Clinics. We've spent a lot of time digging into the deep pathophysiology and the diagnostic nuances of labyrinthitis, right? Well, today we are taking all that evidence and translating it directly into highly effective, actionable management strategies. And we're going to jump right in, because if there's one single takeaway you need for managing this condition, it's understanding windows of opportunity. Taking swift action in that very first week is literally what dictates your patient's long-term recovery trajectory. Delaying things doesn't just put off healing, it actually gives maladaptive behaviors a chance to become completely entrenched. To make all these complex pathways super practical for the clinic, we'll follow the patient journey sequentially. We're going to cover acute pharmacological management, targeted etiological treatments, the vestibular rehabilitation protocol, prognosis and cochlear implantation, and finally, future horizons in therapy. Okay, section 1. Let's get right into the acute pharmacological management, where our decisions are heavily governed by what we call the rule of 72. When it comes to acute treatment, high-dose systemic corticosteroids are absolutely your cornerstone. Based on the major trials, we're talking oral prednisolone at 1 milligram per kilogram per day, capping out at 60 milligrams. But here is the critical part. When you initiate this within the first 72 hours of symptom onset, you improve your patient's hearing outcomes by roughly 40% at 6 months. That is a massive, game-changing functional difference. Now, this brings us to a fascinating clinical dichotomy. While we absolutely must start steroids within 72 hours to save hearing, we have to simultaneously stop vestibular suppressants within that exact same window to save central compensation. Those suppressants are strictly for short-term acute symptom relief. They are not a chronic strategy. In fact, suppressing the vestibular system for too long actively stops the brainstem and cerebellum from adapting to the injury. Think about it. If you keep the brain sedated with meds like prochlorperazine, it simply cannot recalibrate to the asymmetric vestibular input. You are literally pausing their recovery. Prescribing these for weeks is basically prescribing chronic vestibular disability. Moving to targeted etiological treatments, our management has to branch out from that universal steroid rule based on the actual cause of the labyrinthitis. Our care pathways diverge pretty sharply here. For viral presentations, antivirals like valacyclovir have limited independent benefit, but we often use them alongside steroids if we suspect HSV1 reactivation, again, within that 72-hour window. On the flip side, a tympanogenic bacterial labyrinthitis is an absolute surgical emergency. You need immediate IV ceftriaxone and middle ear drainage. And for autoimmune inner ear disease, or AIED, we're escalating to even higher doses of corticosteroids, usually 60 to 80 milligrams, and bringing in second-line agents like methotrexate or mycophenolate for steroid-dependent cases. Now, in meningogenic cases, the whole approach shifts yet again. Here, initiating adjunctive dexamethasone right alongside, or even just before that first antibiotic dose, is absolutely crucial. Randomized trials have shown that this specific protocol cuts hearing loss in bacterial meningitis by roughly 50%. The timing here is incredibly precise, and it's vital. All right, so the acute pharmacological window closes, and that brings us to the vestibular rehabilitation protocol, which is the most powerful tool we have for functional recovery. Getting the patient onto a specific rehabilitation timeline within the first week is, without a doubt, the single strongest modifiable predictor of their recovery. In days 1 to 3, the acute phase, we're focusing heavily on gaze stabilization to promote VOR adaptation. Then, as the weeks roll on, we shift gears into habituation and balance retraining. Getting them on this timeline early is what steers the nervous system away from developing persistent postural perceptual dizziness, or PPPD. I absolutely love this clinical pearl because it completely changes how we counsel our patients. You have to look them in the eye and explain that feeling dizzy during their Cochrane-Cooksey exercises is not a sign of failure. It's not harming them. Actually, that error signal is the essential biological trigger for neuroplastic adaptation. Without experiencing that mild dizziness, the cerebellum simply won't learn to compensate. Let's shift gears to prognosis and cochlear implantation. We really have to separate vestibular recovery from hearing recovery here, because they often go in very different directions. The underlying etiology is the great divider. While 80 to 90% of viral patients get an excellent functional vestibular recovery, bacterial cases face a much darker prognosis for their hearing. This is primarily due to labyrinthitis ossificans. This is where inflammatory damage triggers rapid new bone formation that literally obliterates the fluid-filled spaces of the cochlea. Because that ossification happens so fast, we have this incredibly narrow 3 to 6 month window for post-meningogenic patients. We have to assess them for cochlear implantation urgently. If we wait too long, that new bone completely occludes the scala tympani, and suddenly the standard surgical pathway for the implant is gone. It is a literal race against time.
Before we wrap up the series entirely, let's take a quick look at future horizons in therapy. Our clinical toolkit is evolving so rapidly.
The future is incredibly promising. We're keeping a very close eye on early-phase trials in auto-1 gene therapy, which targets the master regulator of hair cell fate to potentially regenerate mammalian hair cells. On top of that, for our most severely disabled patients, those with bilateral complete deafferentation who just don't respond to standard rehab, electrical vestibular implants are showing real proof of concept by directly stimulating the ampullary nerves to restore the VOR. We are also looking at antiviral prophylaxis for recurrent HSV-1 and some amazing targeted anti-inflammatory biologics for refractory AIED.
All right, let's summarize all this complex pathophysiology and management data into a few key takeaways. If you take absolutely nothing else away from this explainer, I need you to remember these 3 undeniable clinical rules. Number 1, start high-dose steroids within 72 hours to boost hearing preservation by 40%. Number 2, stop vestibular suppressants within 72 hours to unblock neuroplasticity. And number 3, start vestibular physical therapy within the very first week to drive that central compensation and prevent chronic dizziness. And that officially concludes our 6-part Vestibular Physician Labyrinthitis series. I highly encourage you to head over to AustralianDizzinessClinics.com. You can download the full literature review, grab a really handy clinician cheat sheet for your desk, and find some fantastic patient resources to help with your rehab counseling. Thank you so much for engaging with this explainer series. If you want to dive into more evidence-based topics regarding dizziness, vertigo, and imbalance, please subscribe and leave a rating. But before you head back into the clinic today, I want to leave you with one final question to think about. Are you fully optimizing that critical 72-hour window for your next acute patient?